Hello, welcome. My name is Divine. I am a fourth year medical student. Welcome to our 8th episode of the Divine Intervention podcasts. Today we're going to be talking about heme pharmacology. I basically will try to cover every high yield thing you need to know relating to heme pharmacology in this podcast. Okay, so let's go ahead and get started. And for us to start, I think it probably makes sense to discuss the primary coagulation cascade. Okay, so let's assume you get a nick in the skin, right? You disrupt collagen, you disrupt your endothelial cells. That will enable you to express the collagen below those endothelial cells, called the subendothelial collagen, because it's below endothelial cells. Okay, and when you expose that subendothelial collagen, the next thing that happens is you expose von Willebrand factor. And remember that von Willebrand factor is found in two spots, right? You can find it in the Weibo-Palade bodies of endothelial cells and also in the alpha granules of platelets. Okay, so that von Willebrand factor basically serves as a go-between between subendothelial collagen and GP1B9. GP1B9 is a receptor found on the surface of platelets. This is the adhesion step of primary hemostasis. Okay, and remember, if you have a deficiency in GP1B9, that's a Bernard-Souliers disease, right? Basically here your PT and PTT will be normal because there's nothing happening with your clotting factors, and your platelet count will actually be normal. Okay, although classically it's low in Bernard-Souliers disease, but your bleeding time should certainly be increased, and the ristocytin cofactor assay should be abnormal, right? Because anything that impairs the adhesion step of primary hemostasis is associated with an abnormal ristocytin cofactor assay. Okay, so we've talked about the adhesion step. Next step is activation. And basically the thing that happens here is that platelets release ADP from their dense granules, and that ADP binds to the ADP receptor. Okay, that receptor is a GI coupled receptor, so you should already know that its job will be to inhibit adenylate cyclase. If you inhibit adenylate cyclase, you have less conversion of ATP to cyclic AMP. Okay, and in this activation step you also release thromboxane E2. Okay, so again, more thromboxane E2 release, less cyclic AMP. Okay, this whole process triggers the expression of GP2B3A receptors, which heralds the beginning of the aggregation step of primary hemostasis. Okay, and just one quick offshoot factor here is that the cyclic AMP that exists in platelets is broken down by phosphodiesterase 3, right? So PDE3 helps you convert cyclic AMP to AMP. Okay, so if we know that the ADP receptor, also called the P2Y12 receptor, works by a GI coupled mechanism to decrease cyclic AMP, right? We can build a construct that says that low cyclic AMP makes platelets activated. Okay, but if cyclic AMP levels are high, platelets will not be activated, and you potentially exert an antiplatelet effect. Okay, so PDE3, we said it converts cyclic AMP to AMP. If you inhibit PDE3, you have increased levels of cyclic AMP, so you have decreased platelet activity. Okay, now in the aggregation step of primary hemostasis, basically the GP2B3 receptor pairs up with another GP2B3 receptor on another platelet. The thing that marries those two things together is fibrinogen. Okay, remember fibrinogen is factor 1. Okay, as you'll see in secondary hemostasis, we'll convert factor 1 to factor 1A. Factor 1A is fibrin, factor 1 is fibrinogen, the zymogen form. Okay, and you should also please remember that deficiency in GP2B3A is the pathophysiology of Glanzmann's thrombasthenia. Okay, and if you also made autoantibodies against GP2B3A, that will be ITP, immune thrombocytopenic purpura. Okay, so basically these people, they consume their platelets, so they lose the ability to form clots, and it classically presents with bleeding. Okay, classically presents with bleeding. And just as another aside, remember that after von Willebrand factor does its job, right, it's broken down by a protein known as Adams TS13. Another name for that protein is von Willebrand factor metalloprotease. Okay, in TTP, right, which sounds eerily similar to ITP, okay, you have a deficiency in Adams TS13, right, so you cannot cleave von Willebrand's factor. If you can't cleave von Willebrand's factor, you essentially constitutively activate platelets and you have an increased risk of thrombosis. Okay, and then another closely related disorder is HIT, right? So heparin-induced thrombocytopenia. In this case, again, you get thrombocytopenia, but you also have an increased risk of thrombosis. So let's just look at these things real quick. So in ITP, in TTP, and in HIT, you get thrombocytopenia in all three. But in ITP, you have an increased risk of bleeding. In TTP and in HIT, you have an increased risk of thrombosis. Okay. Now, another cascade I want to discuss is basically the cascade that involves the synthesis of prostaglandins. Okay, so basically the thing that happens is your membrane phospholipids, they are converted to arachidonic acid. Okay, the enzyme that does that reaction is phospholipase A2. Remember that phospholipase A2 is inhibited by glucocorticoids. Okay, now from arachidonic acid, you can either go down the leukotriene pathway by using the enzyme 5-lipoxygenase, or the prostaglandin pathway by using the enzyme cyclooxygenase 1 and 2. Okay. So COX-1 and COX-2 will help you convert arachidonic acid to prostaglandins, and it so happens that prostaglandins can be converted to thromboxane A2 by an enzyme known as thromboxane synthase. Okay, but again, 5-lipoxygenase helps us convert arachidonic acid to leukotrienes. Okay, now there are some key differences between COX-1 and COX-2. COX-1 is constitutively expressed, okay, but COX-2 is an inducible enzyme. Okay, and COX-1, you find it a lot in the GI mucosa because remember, right, you need to make prostaglandins. Prostaglandins work through GI-coupled receptors on the surface of parietal cells to decrease the synthesis of cyclic AMP, which ultimately inhibits the activity of the hydrogen potassium ATPase pump, okay, that you find on the surface of parietal cells. Okay, so COX-1, heavily expressed in the GI mucosa, helps you make prostaglandins that decreases acid secretion to protect the stomach lining. Okay, so COX-1 constitutively expressed, COX-2 is inducible. Okay, so if you inhibited COX-1, right, by giving a drug like aspirin, for example, you increase a person's risk of peptic ulcer disease. Okay, because you're removing that protective prostaglandin effect. For the 5-lipoxygenase pathway, right, we said that that helps you go from arachidonic acid to leukotrienes. Remember, you can inhibit that enzyme with xylutone. Okay, we'll talk about xylutone in the Pharmacology podcast. But xylutone basically is a 5-lipoxygenase inhibitor, although it's not used very commonly because it explodes your liver. Okay. Alternatively, you can also get an anti-leukotriene effect by blocking the leukotriene receptor, right? It's called cis-LT1, okay, with drugs like montelukast and zafirlukast. So now that we've talked about these different cascades, let's talk about the antiplatelet drugs, okay? Basically, the big side effect with all these drugs is bleeding, okay? So let's start with aspirin. It's the simpler drug, okay? So aspirin, the way it works is it irreversibly inhibits COX-1 and 2, okay? A few high-yield things you need to know about aspirin. First thing is it has zero-order metabolism. Okay. Remember, there are other things that have zero-order metabolism like phenytoin and ethanol. Okay. And the nice mnemonic you'll learn while you're studying for step 1 is phenytoin, ethanol, aspirin all go like P, like PEA. Okay. And a P looks like a circle, which looks like a 0. Okay. Zero-order kinetics. So that means that basically you lose a fixed amount of the, basically your whatever mechanism is helping you eliminate these drugs eliminates a fixed amount per unit of time, right? So it's like, oh, you lose 5 milligrams per hour. Okay, you don't lose a fixed percentage. Very high yield to know that you lose a fixed amount per hour. Okay, so aspirin decreases the synthesis of thromboxane A2, okay, by inhibiting COX-1 and COX-2 irreversibly. Okay, because if you inhibit COX-1 and 2 irreversibly, you make less prostaglandins, so you're making less feedstock for thromboxane synthase to help you make thromboxane A2. And remember that thromboxane A2 is a potent activator of platelet activation and aggregation. Okay, and as an aside, don't forget that you can give misoprostol to a person to protect the GI mucosa in a person that has to take aspirin chronically. So let's say, for example, they have like osteoarthritis, or they have like like some kind of bad vessel disease like carotid artery stenosis, where they have to chronically take aspirin. You can give those people misoprostol to protect their GI mucosa, because you are basically bypassing the inhibition of COX-1 and 2 that you get with administration of aspirin. Okay, and if they describe a kid that has brain and liver problems, right? So classically, the liver problem is hypoglycemia, and they tell you that the child is in a coma and is somnolent, and this child recently had like a febrile viral upper respiratory infection, or got like some kind of vaccine, like the VZV vaccine or whatever, and they have all these symptoms, and they took aspirin for their fever. Think about Rice syndrome. Okay, very classic association you want to know. People don't really know the pathophysiology, but they think it involves some stuff that has to do with mitochondrial dysfunction. That's like a buzzword you want to remember. Now, the only time you really should be giving aspirin to a kid is if the kid has Kawasaki's disease. Okay. Now, another high yield thing with aspirin is something called aspirin exacerbated respiratory disease. That's like the new term. Back in the day, I believe it was called aspirin-induced asthma. So what's the pathophysiology of this disorder? The pathophysiology here is that if you give aspirin, you inhibit COX-1 and 2, right? We said that arachidonic acid can take one of two pathways. It can take the cyclooxygenase pathway, or it can take the lipoxygenase pathway. So if you inhibit the cyclooxygenase pathway, you increase the flux of substrates through the lipoxygenase pathway. Okay, and we know that leukotrienes, when they act on their receptors, right? So CCLT1, for example, they cause bronchoconstriction, right? So that can trigger asthmatic symptoms. That's why this is known as aspirin exacerbated respiratory disease. Okay, and classically, this disorder on exams presents with nasal polyps. Although you should also keep other high yield things on your differential if they mention nasal polyposis on your exam. So you want to keep things like Wegener's on your differential. Remember, it's C ANCA positive. You want to think about cystic fibrosis as well. Okay. Now, if a person overdoses on aspirin, what happens? The first thing that happens is they get a respiratory alkalosis. Okay, because remember, aspirin can go to the respiratory centers in the medulla and activate them, so it causes you to hyperventilate. But in addition to that, you also get a high anion gap metabolic acidosis. Okay, because if you go back to your biochemistry, hopefully you remember that aspirin is an uncoupling agent of the electron transport chain. Okay, so if you uncouple that, you're like, wait, I'm not seeing any ATP from all my efforts. So you basically upregulate glycolysis, and remember that lactic acid is a byproduct of glycolysis, so that can create a high anion gap metabolic acidosis. Okay, and remember that aspirin is also an acid, right? Acetylsalicylic acid. So again, that should technically decrease the pH of your blood. Okay, now last thing I'll say about aspirin is you want to know what aspirin does at different doses, right? So low dose aspirin, that's usually like less than 300 mg, okay, 300 milligrams, has more of an antiplatelet effect. But high dose aspirin from like 2400 to like 4000 milligrams has more of an anti-inflammatory effect. Okay, and then the next antiplatelet drugs I'll discuss. So we've talked about aspirin. We said that aspirin is an irreversible COX-1 and 2 inhibitor. Drugs like ketorolac and diclofenac are reversible COX-1 and 2 inhibitors. Okay, so these drugs should theoretically increase Km, right? So decrease the affinity, but it should make no changes to Vmax. Contrast that with aspirin. Okay. Now, next drug, celecoxib. Celecoxib is a reversible COX-2 inhibitor. Okay, it does not inhibit COX-1, it just inhibits COX-2. And remember, I already said that COX-2 is inducible, right? So it's induced in states of inflammation. So if you're taking a drug that selectively inhibits COX-2, and we say that, COX-2 is only induced in states of inflammation, you can see that you're basically leaving COX-1 alone, so you don't get the GI problems, right? Like peptic ulcer disease that you get with something that also clobbers COX-1, like aspirin or the other drugs like ketorolac and diclofenac. So these drugs are great drugs. They can give you the same aspirin effect you want, but you don't have any problems in your GI tract. Only problem is, it so happens, at least there's some literature that says that COX-2 is heavily expressed in coronary vasculature, And that should sort of make some teleological sense, right? Because if you think about it, if you're heavily expressing COX-2 in coronary vasculature, you're making more prostaglandin. So remember, prostaglandins are vasodilatory. So that could potentially widen your coronary vasculature and make blood flow more smoothly. Okay? So if you inhibit COX-2, which is heavily expressed in coronary vasculature, you could potentially decrease prostaglandin synthesis. You could potentially cause coronary artery vasoconstriction. Okay? And that person will have an increased risk of a myocardial infarction. In fact, that's why some of these are COX-2s, right? So the COX-2 inhibitors. That's why a lot of them were withdrawn from the market. Okay, so a very unique step one question could be a person having a history of Prinzmetal's angina. I think the new name is variant angina. The COX-2 inhibitors will almost certainly be contraindicated in that population. Okay, so now we've talked about the COX inhibitors. Let's go to the ADP receptor blockers. Okay, remember the ADP receptor is also known as the P2Y12 receptor, right? So drugs in this class include drugs like clopidogrel. It's an irreversible P2Y12 blocker. And then there are other drugs that have exotic sounding names like prasugrel, anticlopidine, anticagrelor. Those drugs, for the most part, are reversible, right? So they are reversible inhibitors of the P2Y12 receptor. Okay. Ticlopidine, I'll say the big thing you want to know with this drug is it increases a person's risk of TTP, thrombotic thrombocytopenic purpura. Okay, so that's all I'm going to say about the ADP receptor blockers. So let's jump on to the phosphodiesterase inhibitors. Okay, in this case, I'm going to spend more time with the PDE3 inhibitors, right? So the drugs that fall under this category are drugs like cilostazol and dipyridamole. Okay, so these drugs inhibit phosphodiesterase, and by inhibiting PDE3, you decrease the breakdown of cyclic AMP, so your cyclic AMP levels actually go up. Okay, and if your cyclic AMP levels go up, that hampers platelet activation. Okay, now let me just quickly take a quick sidebar and discuss a construct relating to cyclic AMP. Okay, high levels of cyclic AMP causes smooth muscle relaxation. Okay, because remember that elevated levels of cyclic AMP ultimately help you activate inhibit myosin light chain kinase and lead to a net activation of myosin light chain phosphatase. Okay, so you have smooth muscle relaxation, you get vasodilation, right? Because remember that smooth muscle lines the walls of most of our blood vessels. Okay, but cyclic AMP does something totally different in cardiac muscle. In cardiac muscle, cyclic AMP actually causes increased contractility. Okay, in a later podcast, I'll probably talk about the phospholamban mechanism in cardiac muscle. But that cardiac muscle with high levels of cyclic AMP, you get contraction. Smooth muscle with high levels of cyclic AMP, you get smooth muscle relaxation. Okay, so if we know that high cyclic AMP causes vasodilation because it causes smooth muscle relaxation, you could potentially imagine that you could use a drug like dipyridamole. It's a PDE3 inhibitor. You can use that in cardiac stress tests. Those tests take advantage of the coronary steal principle. I will discuss that coronary steal principle in a later podcast. Cilostazol, you can actually use it in peripheral arterial disease. Okay, so basically by giving that vasodilator, you can open up the blood vessels that feed the lower extremities. Okay, so you can relieve that pain, right? In fact, it's the only drug that has been shown to improve walking distance in patients that have peripheral arterial disease. Although on your exam, if you get a classic description of a person that has PAD, so person in his 60s and the ankle brachial index is like super low, and they ask what's the next best step in management after you've done the ankle brachial index, the next thing you want to do is to recommend a walking exercise program. Okay, that is the first line treatment for peripheral arterial disease, not cilostazol. Okay, not cilostazol. So that's all we're going to say about the phosphodiesterase 3 inhibitors. The next drugs we'll talk about are the GP2B3 blockers. Okay, so these drugs, they block the GP2B3 receptor, so fibrinogen will have no ability to interact with GP2B3A, and when you have that, you can basically say bye-bye to platelet aggregation. Okay, so the drugs that fall under this category are drugs like apixaban. There's another drug that starts with an E. It's called eptifibatide, and then there is one other drug that's known as tirofiban. Okay. Again, you want to be able to make a parallel between taking these drugs and ITP, right? ITP is basically like a pathologic replication of the pharmacology of these drugs, because remember, in ITP you make autoantibodies against GP2B3A, and classically on exams ITP is tested in the context of systemic lupus erythematosus, okay, so SLE. Okay, so now we've dealt with the drugs that affect primary hemostasis. Let's talk about the drugs that affect secondary hemostasis. Okay, secondary hemostasis. And before we can do that, unfortunately, we have to discuss the coagulation cascade. Okay, so the coagulation cascade is basically the thing that helps us go from a temporary platelet plug to a more permanent platelet plug. Okay, because if you think about it, I sort of think of it this way. If a person has if something really bad happens, like a natural disaster, right, the first thing you go for is like a quick temporizing measure, right? And then after you seek those temporizing measures, when things sort of stabilize a little bit, you then go for more permanent solutions to whatever problems have been created by the natural disaster. That's the same thing that happens when you get a wound, like some kind of bleed. The first thing that happens is you get vasoconstriction of the vessels that are feeding that side of bleeding, right? Because if you constrict those vessels, you bleed less, right? And that's actually mediated by endothelin. You'll see endothelin make a big comeback when we have the pulmonary pharmacology podcast. But after that, you then have primary hemostasis, where you make the temporary platelet plug, which we've talked about. And then the long-term measure is secondary hemostasis, where you basically convert fibrinogen, which is factor 1, to fibrin, which is factor 1A, which forms a more stable fibrin mesh. Okay, so let's discuss the coagulation cascade. There are basically two offshoots of the coagulation cascade. There's the longer one, which is the intrinsic cascade, which we classically follow with the PTT. And then there's the shorter one, which is the extrinsic cascade, which we classically follow with the PT or INR. Okay, so the intrinsic cascade basically starts with factor 12. Okay, so factor 12 is converted to 12A, and then factor 12A converts 11 to 11A, and then 11A converts factor 9 to 9A, and then factor 9A helps us convert factor 10 to 10A. But in the process of making that 10 to 10A conversion, factor 9A actually uses factor 8A as a cofactor. Okay, factor 8A is an example of what I'll describe later as an accelerating factor. Okay, and then when we make factor 10A basically helps us convert factor 2 to 2A. But again, in converting factor 2 to 2A, factor 10A actually uses factor 5A as a cofactor. Okay, so factor 5A is again something we'll describe as an accelerating factor. Basically, accelerating factors are things that help us as cofactors in cleavage reactions of the coagulation cascade, right? So factors 8A and 5A are very high yield accelerating factors. So now we've made factor 2A. Now factor 2A can help us cleave factor 1 to 1A. Remember, factor 1 is fibrinogen, factor 1A is fibrin. Okay, fibrin is the more active form of fibrinogen. Now, one other job of factor 2, in fact, we said that factor 2A helps us go from factor 1 to 1A. Another thing that's done by factor 2A is to help us convert factors 8 to 8A and factors 5 to 5A. Okay, that's another job description for factor 2. Another job description for factor 2A, right, which is also known as thrombin, is that it pairs up with a body known as thrombomodulin, and that complex together helps us convert protein C to activated protein C. Okay, remember, activated protein C is that protein that joins up with its buddy, protein S, to inhibit factors 8 and 5. Okay, to inhibit factors 8 and 5. Very high yield to know that for your step 1 exam. Okay, so that's it for the intrinsic cascade. So let's go ahead and discuss the extrinsic cascade. Okay, the extrinsic cascade, again, like I said, we follow that with a PT and INR. Okay, and basically the way the extrinsic cascade works is that you tissue factor is also known as factor 3. That's like mega low yield for your exam. But basically, tissue factor helps us convert factor 7 to 7A. Okay, and then factor 7A helps us cleave factors 10 to 10A, and then 10A continues the cascade we already described. Okay, And some quick pathology integration here. Remember, if you have a deficiency in factor 8, okay, that's hemophilia A. Okay, remember hemophilia A sounds like 8. Okay, and basically remember your PTT will be increased, but your PT and your bleeding time will be totally normal, because remember factor 8 is a part of the intrinsic cascade. Okay, so factor 8 deficiency is known as hemophilia A, is also known as Christmas disease. Okay, and remember it's an X-linked recessive disease, so it should not show up in girls on your exam. It should show up only in boys. Now, if you have a deficiency of factor 9, right, so that's hemophilia B, right? So the mnemonic you learn while you're studying for step 1 is that B sounds like B9. Remember the word like B9, like vitamin B9, okay? So hemophilia B, factor 9 deficiency. And again, because factor 9 is a constituent of your intrinsic coagulation cascade, your PTT will be increased, but your PT will be normal, and your bleeding time will be normal as well, okay? And again, factor 9 deficiency, hemophilia B, is X-linked recessive, so it should only show up in boys on your test. Now, if you have a deficiency of factor 11, that is what is known as hemophilia C, okay? And basically, this one does not have X-linked recessive inheritance. It has only autosomal recessive inheritance. So, if you get a question on step 1 about a person that has like bleeding into joints or bleeding into soft tissues, and they tell you that the PTT is elevated, or you see the disorder in a girl, you should have a very good reason for not picking hemophilia C as the underlying pathology, okay? And contrast these hemophilias with von Willebrand's disease, right? In von Willebrand's disease, you have a deficiency of von Willebrand factor. We say that von Willebrand factor helps us in the adhesion step of primary hemostasis, but it also helps to protect factor 8. It serves as a protecting group for factor 8. So basically, in the presence of von Willebrand's factor, we actually have an increased half-life of factor 8 in the serum. So if you have VWD, which is a VWF deficiency, your bleeding time will be increased because your platelet is not functioning well. Your platelet count will be normal because remember, VWD is a qualitative platelet disorder. It is not a quantitative platelet disorder. And the PTT will be increased because you have a decreased half-life of factor 8 in the serum, but your PT will be totally normal. And as an aside, remember that your ristocytin cofactor assay will be abnormal, just like we had in Bernard-Soulier disease, because these are problems with VWD is a problem with platelet adhesion in primary hemostasis. Okay, and remember that von Willebrand's disease is autosomal dominant inheritance, and you actually treat that with desmopressin. Okay, I remember desmopressin is an ADH analog. It increases the release of von Willebrand factor from Weibo-Palade bodies in endothelial cells. And you may be like, why does this make any sense? Right? So think about it. If von Willebrand factor helps you form clots, right? And that if you form a clot, you stop bleeding. If you stop bleeding, your blood volume is maintained. So it should sort of make sense that ADH, which has maintenance of blood volume as one of its primary jobs, it should make sense that one of the things it does is to increase the release of something that helps you form clots, so you bleed less and maintain blood volume. Okay, and you can actually use desmopressin. In addition to treating von Willebrand's disease, you could use it to treat hemophilia A, okay? Because again, if you give desmopressin, you increase the release of von Willebrand factor. Whatever little factor 8 you have floating around in the serum, you can increase their half-life if you have more von Willebrand factor around. You can also use desmopressin, especially the intranasal form, to treat central diabetes insipidus, right? So that's where you basically have failure of the supraoptic nucleus in the hypothalamus, so you're not making ADH, so you waste a lot of urine, right? So hopefully you remember that in diabetes insipidus, you have a high serum osmolality and a low urine osmolality because you're not retaining fluid in the urine at the level of the collecting duct principal cells. Okay, so now we've talked about the coagulation cascade. Now let's talk about the anticoagulants, okay? So basically drugs that affect secondary hemostasis. So the first drug we're going to talk about is heparin, okay, and oxapirin is a classic heparin example, okay. Basically, the way these drugs work is that they activate antithrombin 3, and antithrombin 3's job is to inhibit factors 10 and 2, Okay, so by inhibiting factors 10 and 2, you do not form clots. Okay, so you monitor heparin with the PTT. Okay, although here's one thing your friends at the MBME would love to do to you on exams. Okay, yes, we monitor heparin with the PTT, but when you're taking heparin, your PT and your PTT will both be elevated. Okay, we use PTT to monitor heparin, but remember, heparin, we said it activates antithrombin 3 to inhibit factor 10, which granted is a part of the is actually a part of the common final pathway of the coagulation cascade and factor 2, which is also a part of the common final pathway. Okay, so your PT and your PTT will be elevated when you take heparin. Okay, so if they give you these arrow questions, your PT and PTT should both go up on heparin, not just your PTT. Okay, very high yield to know that. And heparin is pretty safe in pregnancy because it's heavily protein bound. So if it's heavily protein bound, it has a very tough time crossing the placenta. Okay, now some more high yield things with heparin, right? So HIT, heparin induced thrombocytopenia. So the classic way it presents on exams is a person recently got surgery, they got heparin, and then 5 days later, boom, their platelet count has dropped by 50% or more. If you see that, think about HIT. Okay, and if this is a first time occurrence, it takes a few days for your platelet count to go down that much. But if you get another heparin product in the future and you've previously had HIT, you can actually have early onset HIT where like the problems show up within like a day. Okay, so keep that in mind. That can be a very nice way for them to integrate immunology with heparin. Okay, so what's the pathophysiology of HIT? Basically, the thing that happens is platelets have a receptor called a platelet factor 4. Heparin can bind to this platelet factor 4, and that complex of heparin with platelet factor 4 can do two things. Okay, the first thing it can do is it can activate platelets. So again, by activating platelets, you can increase a person's risk of thrombosis. So HIT is actually a hypercoagulable disorder. The second thing that's done by this heparin platelet factor 4 complex is that your body can actually form autoantibodies against this complex, like IgG. Okay, remember that IgG has a constant region, and that constant region can be bound by an Fc gamma receptor that you can find on the surface of macrophages, for example, in the spleen. Okay, so basically the thing that happens is macrophages, they use their Fc gamma receptor. I believe that receptor is CD56, but I'm not 100%. It's either CD16 or CD56, but if I had to guess, I would say CD56. I'm not really sure, to be honest. So the Fc gamma, so let's scratch that then. Let's just say Fc gamma receptor binds. I'll try to find out and let you guys know in the next podcast. But basically, Fc gamma receptor binds the constant region of IgG that's already bound to the complex of heparin and platelet factor 4. And basically, you phagocytose the platelet, and that's the mechanism behind the thrombocytopenia that you get in heparin-induced thrombocytopenia. Okay, and remember that this is basically a kind of type 2 hypersensitivity reaction because you're forming autoantibodies against your own cells. Okay, platelets in this case. Okay, now on your exam, they'll usually ask what's the next best step in management in a person that has HIT. The first thing you want to do is to obviously stop the heparin. Okay, but do not give them any other heparin product in the future. Classic exam answers to offer low molecular with heparin. Yes, the risk of HIT is low with low molecular weight heparin, but it's not zero. Okay, so giving low molecular weight heparin is never the right answer as a treatment for HIT. The treatment for HIT, classically on exams, the more common answer choice is to give a factor 2 inhibitor. Okay, those are called direct thrombin inhibitors. So drugs like lepirodine, bivalirudin, dabigatran, and agatroban. Okay, I'll repeat those again: lepirodine, bivalirudin, dabigatran, agatroban. Okay, they are factor 2 inhibitors. Alternatively, you can give factor 10 inhibitors, right? So you can give drugs like apixaban and rivaroxaban. Remember, those drugs have XA in the name, so that helps you remember that they are factor 10A inhibitors. Okay. Now, one quick thing I'll just go ahead and say is these factor these factor 2, factor 10 inhibitors, classically the teaching was that none of these drugs are reversible. You cannot reverse any of their deleterious effects. Like, let's say a person starts bleeding on agatroban. Oh, there's nothing you can do. It so happens that dabigatran, right? Dabigatran is actually now reversible. If you've ever worked in a hospital, dabigatran is known as Pradaxa. There is now a monoclonal antibody against Pradaxa. It's called Praxbind. That's the trade name, but the actual drug name is it's a monoclonal antibody. It's known as idarosizumab. That is certainly something you want to know for your exam. I'm pretty certain I've seen that in the 2018 version of First Aid for the USMLE Step 1, so just don't forget that. Okay, so dabigatran is now in fact reversible with a drug known as idarosizumab. So that's it for HIT, okay? And the last thing I'll say about heparin before we jump to low molecular weight heparin is that if a person is bleeding from heparin, they have like heparin toxicity, you go ahead and give them protamine sulfate, okay? Protamine sulfate is a positively charged molecule. It binds up negatively charged heparin, okay? And heparin, you can actually use this to treat antiphospholipid antibody syndrome, okay? Because that's a problem that classically shows up in pregnant women. Pregnant women should not be put on warfarin, okay? So you give something that's safe in pregnancy, like heparin. They classically give it in the belly. Kind of disturbing, actually. Okay, so low molecular weight heparin, I'm not going to say much else here. Basically, it activates antithrombin 3, just like regular unfractionated heparin, but it activates antithrombin 3 primarily to inhibit factor 10. Okay, and instead of using the PTT to monitor low molecular weight heparin, you can actually do a factor 10 activity. Okay, that's how you monitor low molecular weight heparin. Okay, and just an aside with antithrombin 3, remember that antithrombin 3 is one of the proteins that you lose in the urine in nephrotic syndrome. Okay, that's why nephrotic syndrome is a prothrombotic state. Okay, so one classic thrombotic effect that they could test on exams relating to the nephrotic syndromes like membranous nephropathy, for example, is if they describe a person that has membranous nephropathy or any other kind of nephrotic syndrome and then they present with flank pain, sudden onset flank pain, you really want to think about renal vein thrombosis with that. Again, the thought is by losing antithrombin 3 in the serum, you have less inhibition of factors 10 and 2, so you form more clots, okay? And while we're on the subject of thrombosis, another aside, I guess a sidebar, is that you should also associate splenic vein thrombosis as a complication of pancreatitis, okay? It's just one of those things you want to file away in your mind. And then another kind of thrombosis you can also file away in your mind while we're on this subject is hepatic vein thrombosis, right? That's Budd-Chiari syndrome. Classically on exams, they test that in the context of people that have like polycythemia vera. Remember the association of that with a JAK2 mutation. It's also common in people that take, it's like super rare, but it's pretty common on exams. You should also remember the association of people that are taking like OCPs. Okay, OCPs, especially a person that takes OCPs and is a smoker. Think about if they present with like right upper quadrant pain, sudden onset, and they have like ascites and all that stuff from portal hypertension. Think about Budd-Chiari syndrome. Okay, Budd-Chiari syndrome. That's thrombosis of the hepatic vein. Okay, very high yield to know those thrombosis syndromes. So now we're done with heparin. Let's go ahead and talk about warfarin. Okay, so warfarin, I'll give you a quick preamble first. Okay, so basically, factors 2, 7, 9, and 10, and protein C and S, all these proteins require gamma carboxylation to make the active forms. Okay, so if you want to make activated factors 2, 7, 9, and 10, and protein C and S, you do need to gamma carboxylate them. Okay, and that gamma carboxylation is done by reduced vitamin K. Okay, vitamin K acts as a cofactor for that gamma carboxylation. Okay, but because it's a redox reaction, right, as you use reduced vitamin K for the reaction, it's ultimately converted to oxidized vitamin K. So if you want that reaction to go in the future, you want to take that oxidized vitamin K and get it right back to reduced vitamin K. Okay, the enzyme that helps you go from oxidize to reduce vitamin K is an enzyme known as vitamin K epoxide reductase. Okay, vitamin K epoxide reductase. So the way warfarin works is that it inhibits vitamin K epoxide reductase. If you inhibit vitamin K epoxide reductase, you do not regenerate reduced vitamin K, so you're basically not regenerating a cofactor for the gamma carboxylation of factors 2, 7, 9, and 10, and protein C and S. That is how warfarin exerts its anticoagulant effect. Okay, so remember, activated protein. So a few more things with that. Some other things you can test with warfarin is that remember that activated protein C helps you inhibit factors 5 and 8. Okay, and remember I said that to make that activated protein C, you need factor 2A, thrombin, pairing up with a body thrombomodulin. Okay, to convert protein C to activated protein C. Okay, and then activated protein C pairs up with protein S as a cofactor, and that helps you inhibit factors 8 and 5, which, as we said, you're accelerating factors. Okay, so if you really think back to what I've said earlier, this is sort of like a negative feedback mechanism of factor 2 on the activation of the accelerating factors, because remember, factor 2 activates factors 8 and 5, but in addition, factor 2 activates protein C to help you go back and inhibit factors 8 and 5. Okay, so just some nice tying there. So the thing is, factors 2, 7, 9, and 10, right? They are procoagulants. Okay, they have a long half-life. Contrast that with protein C and S, they are anticoagulants and they have a short half-life. So in the first few days after a person gets warfarin, the anticoagulant effect actually goes away first. Okay, so you have a transient procoagulant state, because again, remember, the anticoagulants, protein C and S, have a shorter half-life than the procoagulants, factors 2, 7, 9, and 10. Okay, so in the first few days while a person is getting warfarin, you do need to bridge those people with heparin. Okay, so that you can take care of their transient hypercoagulable state, because factors 2, 7, 9, and 10 have a longer half-life than protein C and S. But if a person, if for example they want to make a question really hard and they say, oh, a person is about to be put on warfarin and they have a history of HIT, instead of bridging them with heparin, you can bridge them with a factor 2 or factor 10 direct inhibitor. Okay. Now, one of the derivative concept with this is, what if they give you a question about a person that has a protein C deficiency or protein S deficiency? The thing is, if those people already have that deficiency, when they take warfarin, it's like that minute anticoagulant effect you get from protein C and S before they drop out of circulation, it's no longer there. So those people actually have a much higher risk of hypercoagulability, like transient hypercoagulability side effects with warfarin. Okay, classically on exams they test people that have protein C and S deficiency as getting skin necrosis after a recent administration of warfarin. Okay, very high yield to know that. Now, how do you reverse the effects of warfarin? Well, if you can wait a couple of days, you can give vitamin K. Okay, but if you need very quick reversal, you can actually go ahead and give a fresh frozen plasma. Okay, you give a fresh frozen plasma. Okay, fresh frozen plasma can help you very quickly reverse warfarin's effects, because it contains activated forms of the clotting factors that have been clobbered by the administration of warfarin. Okay, so that's it with warfarin. So to round up, we'll just talk about a few more drugs real quick. So let's talk about the clot busters. Your clot busters include drugs like alteplase, ritaplase, and tenecteplase. Okay, so these drugs are clot busters. They all have plase in their name. Although I guess streptokinase is another one you can think about. So these drugs, they basically aid the conversion of plasminogen to plasmin, and then plasmin goes and cleaves thrombin and fibrin clots. Okay, so when you give these drugs, obviously your PT and PTT will go up, right? Because whatever clots your hang on, your PT and PTT going up. Why would your PT and PTT go up? Actually, I don't think your PT and PTT will go up with these drugs, because they are working after you form the clot, not before you form the clot. Yeah, so your PT and PTT, I may be wrong on this, so I'll have to look this up, but I will prognosticate that PT and PTT does not go up when a person takes clot busting drug. I would imagine that your PT and PTT should be unaffected if I'm just reasoning with pure physiology. So I guess I have two things to discuss at the next podcast. What happens to PT and PTT when a person takes a clot buster? And what is the Fc gamma receptor for platelets? Oops, not for platelets. For IgG. Is it CD16 or CD56? Those are two things I will address at the next podcast or some future podcast. Okay, so those are your clot busting drugs. Okay, if you want to reverse these drugs, so let's say you're giving a person a clot buster, they're bleeding everywhere. For example, let's say they had a PE, give them the clot buster, they're bleeding like no man's business. The way you can reverse those drugs is to give drugs like aminocaproic acid or tranexamic acid. Okay, you can use those to reverse the clot busting effects of alteplase, reteplase, tenecteplase, and streptokinase. Okay, and actually, an unusual exam question you could get is a person that has like excessive postmenopausal bleeding or very nasty menorrhagia. You can actually give tranexamic acid to basically prevent the body from breaking down clots so that you can sort of stop the bleeding. So that's an unusual question you could get on your board exams. Also something that may show up on an OB-GYN shelf in your third year, or in step 2, or in step 3, who knows. Okay, so another drug I'll talk about is eculizumab. Eculizumab is a monoclonal antibody against C5. Okay, remember C5b through C9 help you form the membrane attack complex that basically blows holes in cells. Okay, so eculizumab, it's a monoclonal against C5. It prevents the membrane attack complex from forming, so you do not explode cells. Now, what is eculizumab used for? Eculizumab is actually used to treat PNH, paroxysmal nocturnal hemoglobinuria. And let's just quickly discuss the pathophysiology of this problem. Okay, in PNH, you basically have a PIG-A gene mutation. Okay, PIG-A, the gene, if you unscribe those letters, PIG, at least unscribe PIG. PIG, if you unscribe the letters, you get GPI. Okay, the PIG-A gene encodes the protein products which are GPI anchors. Okay. These GPI anchors are basically flagpoles for stuff on the surface of your cells. Okay, so some important stuff on the surface of your red cells, for example, are things like CD55, which is known as decay accelerating factor, and CD59. Okay, these two things, they basically help you prevent complement from exploding your red cells. Okay, so if you have a mutation, or I guess a deficiency in these GPI anchors, you don't have CD55 and CD59 on the surface of your red cells, your red cells will explode, okay, and you will get an intravascular hemolysis, right? So hopefully you remember the markers you have with intravascular hemolysis, right? So you will have a decrease in your haptoglobin, you'll have an unconjugated hyperbilirubinemia, okay? So sort of things I guess to keep in mind with that. Okay, so classically on exams, this shows up as a young guy that has like a lot of red urine in the morning. And you may be wondering, why is this person forming red urine in the morning? Like, do they not form red urine at other points in the day? They do. They actually form red urine at other points in the day, but they just form more in the morning. Because the thing is, when you sleep, you hypoventilate. You're not like sleeping and doing like it's only if you have like a nightmare or you're doing something that I think you can imagine. I'm not going to mention it. But basically, if you hypoventilate as you're sleeping, you get a respiratory acidosis, your blood pH falls. Reduced blood pH actually activates complement. Okay, so if you activate complement more while you sleep, you have more intravascular hemolysis because you have PNH. So you form more red urine in the morning. Okay, so that's the mechanism behind that. So if a person had sleep apnea, for example, right, they potentially have more intravascular hemolysis in PNH. So I guess another like weird association to keep in mind. So the way you treat PNH is to prevent that membrane attack complex from aggregating on your red cell by forming a monoclonal against C5. Okay, that's how eculizumab works. It's an extremely expensive drug. Costs hundreds of thousands of dollars per year. But it basically cures PNH. It basically makes you live as long as like a normal human being. So it's a blockbuster drug. Okay, now just some quick like one word associations to round this up. If a person has like anemia of chronic disease or anemia from like kidney failure, you want to go ahead and give those people EPO, right? Occasionally they may call it like erythropoietin or dabrapoietin on exams. Dabrapoietin is an EPO analog, okay? And please, you know what, I'll mention that in a later podcast. Let me let that go for now. Another classic exam question: a person is getting chemo and you knock down their white cells. The way you can spruce those people's white cell numbers back up, you can give a drug like filgrastim. Filgrastim is a GCSF analog, so granulocyte colony stimulating factor analog. So it spruces up your neutrophil counts. Alternatively, you can give sagramostim. Sagramostim is a GM CSF analog, right? So it's a granulocyte monocyte colony stimulating factor analog. Okay, that's used more for leukopenia. Okay, versus filgrastim that is used more for neutropenia. Okay, and then if a person has a low platelet count, let's say they had like some kind of aplastic anemia or whatever, you can give them an interleukin 11 analog, because remember IL-11 helps your megakaryocytes differentiate. So if a person has severe thrombocytopenia, you can give an interleukin 11 analog like oproviken. Okay, oproviken. So I think that's all I'm gonna say with heme pharmacology. I will make another podcast down the line that covers onc pharmacology, but I personally think that if you know everything in this podcast, you know everything you need to know within reason for heme pharmacology for your board exams and for the future. So I wish you all the best as you study, and I'll see you at the next podcast. Have a wonderful day and stay blessed.